Hi all. So in this video we're going to see about physiological basis questions that can be asked from RBC. So I'd already done a part 1 before, so this is a part 2 of those physiological basis questions. So let's start. What is the physiological basis of pigment gallstones in hemolytic anemia? So we know that in hemolytic conditions like hereditary spherocytosis there can be pigment gallstones present. Why is it so? Well, it's because whenever there's an increased RBC breakdown, there is increased unconjugated bilirubin released from the RBC. And moreover, the conjugation of the liver is limited. The liver may not be able to conjugate all the bilirubin that is coming to it. So there will be increased amount of unconjugated bilirubin also released into the bile, which can lead to gallstone formation. So basically here the pathology is increased RBC breakdown leading into more release of bilirubin. Okay. Second, why is splenectomy done in hereditary spherocytosis? So in hereditary spherocytosis, one treatment modality is splenectomy, especially in cases with complications. Why? Because spleen is a site of destruction of RBC, and in hereditary spherocytosis the RBCs are all spherical. So spherocytes are more rigid, and they get to be destroyed faster as it passes through the spleen. So once you remove that spleen, you can increase the lifespan of RBC, and thus splenectomy is a treatment for hereditary spherocytosis. Now, vitamin B12, not folate deficiency, is associated with neurological diseases. See, we know that both vitamin B12 as well as folic acid produces megaloblastic anemia. But the difference between the two is that it is only vitamin B12 that is associated with neurological disease. Why? That is because vitamin B12 has got an important role to play in the conversion of methylmalonyl-CoA to succinyl-CoA. So cobalamin is a vitamin B12. It converts methylmalonyl-CoA to succinyl-CoA. So when there is vitamin B12 deficiency, this does not occur properly, and thus there will be accumulation of this methylmalonic acid, and this can lead to demyelination of the dorsal column as well as the lateral spinal thalamic tract, and thereby cause neurological symptoms, especially glove and stocking paresthesia. So it is due to accumulation of methylmalonic acid that there is demyelination and there is neurological symptoms. Next question, physiological jaundice. What is the physiological basis of physiological jaundice? We know that physiological jaundice is a yellowish discoloration of skin and mucous membrane occurring in newborns, typically 2 to 3 days after birth, and it usually resolves within 2 weeks. So what are the different causes or physiological causes of this physiological jaundice? First of all, we know we've got increased RBC breakdown for these babies because their number of RBCs are more. So there is increased RBC breakdown. So naturally after birth there is increased destruction of RBC, which means there will be elevated serum bilirubin, and thereby it can result in jaundice. So one cause for physiological jaundice is increased RBC count. Secondly, their liver is also immature. So there is a delayed liver function, and thus after birth when all this bilirubin reaches the liver, it is not able to handle them. So liver takes time to fully take over the bilirubin conjugation and excretion through the bile. And thus this delay, it's especially seen in premature babies due to hepatic immaturity. So this delay of liver function is also another reason for physiological jaundice. So there are two reasons: one, increased RBC count, and second, delayed liver function. Now next question is what is the basis of using phototherapy in neonatal jaundice? So we know that in neonatal jaundice the problem is we've got excess of bilirubin. So this bilirubin, when we do phototherapy, it is converted by photoisomerization to a more soluble form, lumirubin. So the liver cannot conjugate and make the bilirubin water soluble. Instead, we use phototherapy to convert this bilirubin into a water soluble form through photoisomerization. And this lumirubin can be excreted via bile without the need for conjugation, and thus we use phototherapy for neonatal jaundice. Our next question is, why is there sickle RBC in sickle cell anemia? See, we know that the normal RBC is biconcave disc shape, but if the person has a sickle cell anemia, the RBCs will be converted to a sickle shape, especially during deoxygenation. So it is because of HBS. HBS is a type of hemoglobin that is present in sickle cell anemia. This HBS becomes less soluble. It precipitates into crystals within the RBC under low oxygen tension or low pH. So the crystals will elongate, changing the cell shape from biconcave to sickle shape. So this is the reason for sickling. That is, the HBS is less soluble, so they will precipitate into crystals within the RBC. It's actually called tactoids. Anyway, they precipitate into crystals within the RBC under low oxygen tension or low pH. So the crystals will elongate, changing shape from biconcave to sickle shape. Okay, so that's the reason for sickle RBC in sickle cell anemia. Finally, why is there Bart hemoglobin in thalassemia? What is Bart hemoglobin? Bart hemoglobin is a condition in which you have 4 gamma chains instead of the usual 2 alpha 2 beta. You have 4 gamma chains. Now, why is it so? This is especially seen in thalassemia, because in thalassemia there might be impaired alpha chain production. So you don't have beta, and your alpha chain production is affected. So in that case you will have 4 gamma chains. That is why it is called Bart's hemoglobin, and it is seen in thalassemia. Okay, so that was some of the physiological basis questions that can be asked from RBC. So see you. I hope this was useful for you. Thank you.